Michael. It's an absolute pleasure to be. It's a pleasure to be wedged between Sanjay and Han Hardbuchel because one, they're excellent talks, but secondly, all the controversies removed. Sanjay's talked about whether or not exercise is a good or a bad thing, and Prof. Hardbuchel will talk about the arrhythmias. I'm just going to describe the physiology. And it reminds me of a story I was once told about one of UK's most famous bank robbers, who apparently after robbing his 50th bank, one of the journalists said, "Why do you keep robbing banks?" And he said, "Because that's where the money is." And all I want to do to convince you here is that if exercise is good or bad for you, if arrhythmias are more common, the place to look is the right ventricle, because the right ventricle is the thing that's put under greater stress during exercise. And the history of cardiology, the term always used is the forgotten ventricle, and indeed the right ventricle has been overlooked. And this is a situation where the right ventricle shouldn't be overlooked, it should be focused upon. So I'm going to give you 4 lines of evidence that tell you that the right ventricle should be considered the Achilles heel of the athlete's heart. Firstly, from a hemodynamic point of view, during acute exercise, it is placed under greatest hemodynamic stress. Secondly, after prolonged exercise, the right ventricle suffers disproportionate fatigue or injury. Thirdly, the right ventricle is most affected when it comes to chronic remodeling after many years of exercise training. And fourthly, but something that the next speaker will discuss, is that it may be associated with arrhythmias in some athletes. Now the physiology. Anyone who wants to go to sleep for the next 20 minutes can do so, because the last 4 slides of my talk will summarise everything that precedes it. But basically, the right ventricle, we now know on the left panel here, we've known for some time, that we can measure pressure volume loops just as we can for the left ventricle. And what we find is that contractility in the right ventricle is less than the left ventricle. I'm not sure if I get a laser pointer here, but what does black do? Aha. Thank you. So here, if we look at ventricular elastance, the contractility for the right ventricle, we can also measure arterial elastance. So this is the push of the ventricle, and this is the stiffness or resistance, if you like, of the vasculature. And just as for the left ventricle, these two things are tightly coupled. And we know that the stiffness, the resistance of the lungs is very low relative to the systemic circulation, and therefore it requires less push. And we can see that. We can see that when we're doing an echo every day. It looks like the right ventricle's doing nothing. At rest, 20% of the afterload of the systemic ventricle, roughly, 20% of the contractility, 20% of the mass, 20% of the mass, 20% of the coronary supply and oxygen utilisation. So my point here is that whilst you're all sitting there, every single one of you do not need your right ventricle. It is doing close to nothing. And an adept surgeon could come around and remove your right ventricle and you would be perfectly fine. We know that from the Fontan circulation. However, the person sitting up the back with pulmonary hypertension desperately needs their right ventricle, and they would be dead without it. Because as soon as you load the right ventricle, its function becomes critically important. Most commonly, we see that in left ventricular failure or biventricular failure, because it's the most common setting by which the pulmonary pressures are elevated. And in that setting, we know that right ventricular function is an independent and powerful prognostic predictor of outcomes. Pulmonary hypertension or pulmonary vascular disorders put a load on the right ventricle, as does things like an atrial septal defect with increased preload. But what I will be focusing on here is that for all of you sitting here who do not have A, B or C, but what you do is get up from the conference here and run for the bus. And at that point, your right ventricle becomes critical. And hence, refer to the right ventricle as the exercising ventricle at the time in which there is increased wall stress, increased work and increased oxygen demand. And so when you exercise, your pulmonary artery pressures go up. And I'll go into our data here on the left in some detail. But one important thing is that these measures are derived from echocardiography. A group from Brussels in Belgium have done very similar experiments and come up with almost exactly the same regression coefficient and relationship between cardiac output and pressure. And here, in a group from Boston, they measured the same thing with invasive data. And we're also doing invasive data, and that data is singing the same tune. So really, I think it is basically proven now that the more you exercise, the higher your flow, the higher your cardiac output, then there's an almost linear relationship with pulmonary artery pressure. The harder you exercise, the more the right ventricular work. What we don't know, and what there's very little data on, is how that is similar or different to the left ventricle. So we set about trying to compare the left and right ventricles as comprehensively as we could, including not just pressures, but also measures of wall thickness at rest and then during exercise, so we could put it all together under the framework of the Laplace relationship and quantify it as wall stress. So we used cardiac MR measures for volumes and wall thickness, and echocardiographic estimates for pressures of the pulmonary circulation and radial arterial line for systemic pressures. This is really sort of a summary of the methodology used, and you can see perhaps down here with the echo Doppler trace and pulmonary artery pressures, which you won't be able to read, but of 80 millimetres of mercury, and you can see that these are quite reasonable traces. And we certainly reproducibly show that, and as I just mentioned before, now with invasive measures in well-trained athletes, we get pressures certainly of this or even more. Now, what we found was for the left ventricle that wall stress increased. But the increase was fairly modest and no different between athletes and non-athletes. The p-value here representing the interaction or the difference between the two groups. Whereas for the right ventricle, a lower resting result, but a more substantial increase and greater in the endurance athletes, which is to be expected given what I just said. The more you exercise, they had greater exercise capacity, the more strain and stress you can put on the right ventricle. If we put everyone together, just comparing the LV with the RV, here's what I told you at the beginning, which is at rest, the RV is required to do a lot less wall stress, less work, less oxygen demand. But then during exercise, all of a sudden the same amount of work is required approximately as for that of the systemic ventricle. And that's fine, except that it's built for much lower work capacity, if you like. And we've seen this slide before, but this is sort of a summary. The fact that your systemic vascular resistance is moderately high at rest, whereas it's very low in the lungs, really resulting in more of a diminished capacity to reduce that during exercise. It basically all comes down to hoses. In the systemic circulation, you have a whole lot of hoses and vascular territories of different sizes, ability to shift things around, resulting in a greater reserve. In the pulmonary circulation, you have a very uniform vascular size, only a short amount of large vessels before the whole body circulation is needed to push through the capillaries. And that comes with some limitations. Now, I'm simplifying things a bit because, of course, your hoses in the body are not steel pipes. And they're not just simply the size of the pipe that matters, but also its distensibility or elasticity, if you like. What you want is big pipes to get as much flow down as possible, big pipes that then in a pulsatile circulation can also stretch. That's the way of getting the very most flow down any vessel. And in fact, we believe that we can study this using an echocardiographic surrogate. So here we've injected some agitated gelifusine contrast, and the bubbles, as we do for a lot of studies in cardiology, looking for shunts, etc., the bubbles go into the right ventricle, but do not go through the pulmonary circulation. They're too large. But then look what happens during exercise. The bubbles go into the right ventricle. After 5-6 beats, after having time, they then traverse the pulmonary circulation. And you can actually see, not so well here, but the bubbles coming in through the pulmonary veins here. So these are not intracardiac shunts, these are bubbles passing through the pulmonary circulation. We looked at these bubbles under a microscope, and the mean diameter is 21 and capillaries are 6 to 8. So essentially these bubbles just shouldn't get through, but then during exercise something happens whereby they can, and we believe that's that the vessels get bigger and allow greater flows. So to test this, we divide our population, which quite nicely divided up almost into half with not many bubbles. Almost everyone had at least some bubbles. And then into those with copious amounts of bubbles. And this is the graph I showed a little earlier. And this compares athletes and non-athletes with the relationship between exercise intensity or cardiac output, very similar, against pulmonary pressures. And what you'll see is that the relationship is virtually identical. The more you exercise, the more the pressures will go up in a very predictable way, but the non-athletes here stop because they're just not as well trained. The athletes go higher, and therefore you have a higher pressure. But then, if you look at these two things by bubbles, then the red line is those with not many bubbles going through. They have either smaller or less stretchy pipes, if you like, and the pressures go up more for any given exercise intensity, any given cardiac output. Therefore, a suggestion that pulmonary vascular resistance is lower in those who have more bubbles going through, exactly per theory. And also we found those with more bubbles had a greater cardiac output and they had a higher VO2 max. Also, as I said at the beginning, the RV is highly linked to pulmonary function, and we found better right ventricular function in those with more bubbles. And finally, because BMP is a measure of ventricular stretch, in this case we're implying the right ventricle, and that was lower in those who had more bubbles going through. So essentially, on that little sidetrack, what I'm suggesting is that amongst this audience, athlete or not, you have this intrinsic variability in how big and stretchy your pulmonary vessels are. And if you are one of those people with bigger and more stretchy vessels, then at any given exercise intensity, the pressure on your right ventricle is less. Or put another way, because for athletes they tend to go to capacity, is that you can reach the point at which your pulmonary pressures become the same, whether or not you have bubbles, but if you have stretchier vessels, you will have a higher cardiac output and exercise performance. But it's a nice demonstration of how the pulmonary circulation defines right ventricular function. The next question is, if we've got pressures of 80 to 90 and big wall stress when you're really exercising hard, can the right ventricle cope? And I'm going to summarise this quite quickly, and I'll say yes. And we've looked at this with some sort of novel echo approaches, looking at areas and with pressures, and then also with deformation during short, up to 15 minutes of intense exercise. And we can use these deformation measures even at quite high heart rates. And even though there's really quite some scatter here, the point is that as pressures increase and as the intensity of exercise increases and the heart rate increases, so does your strain rate, suggesting that contractility is able to match, if you like, the increased load. But how long can it do that for? And here's the crunch, if you like, because the right ventricle is put under all this stress, it responds, but for how long? Just as you can run hard for 15 minutes. Your legs at some point say enough's enough, and the data I'm about to show you, I think, suggests that the right ventricle says the same thing. So we looked at the right ventricle again using, because we'd already performed a study where really as a surprise we found that the right ventricle was the source of dominant injury. We used all the tools we had to best look at the right ventricle. So we used 3D echo, deformation, and then typical measures. And this slide demonstrates that every single measure that we chose to look at the right ventricular function was reduced immediately after an endurance race, whereas none of the left ventricular measures were abnormal. Using the 3D echo, we were able to demonstrate that the dysfunction is associated with acute dilatation of the right ventricle. And so the left ventricle becomes somewhat squashed has difficulty filling, and therefore really the overall cardiac output and exercise performance toward the end of these races may be determined by this right ventricular dysfunction. We're not alone in showing this. Recently, every study that's looked at ventricular function after a race that has included right ventricular measures has shown right ventricular dysfunction, and more so than the left ventricle. It includes work by Rob Shave and Dave Oxborough, groups from Canada, Musavi, Neelan from Boston. It's a consistent tune now that the right ventricle is more greatly affected. Now, let me give you some examples. Here's one athlete with typical athlete's heart, low sort of normal function of both ventricles. The TAPSE, the annular movement, up and down. You can't really see the endocardium so well here, but it's thickening and the area is reducing. Here, you can measure the area with your eye. It hardly changes. The annulus is jiggling rather than sort of making any meaningful movement. This is severe RV dysfunction. Here's another athlete, and as you can see, if you look at the apex here as compared to before, it's still somewhere out on the race course. And if you look at regional deformation, his apical strain has gone from nearly 30% down to 14%. And finally, as I was mentioning before, I'm just going to have to, well, you can almost see it from the still, but this flattening of the septum and sort of squashing of the left ventricle and dilation of the right ventricle, which I'll actually be able to show, hopefully, except everything's stalled now. Beautiful. The other thing that we demonstrated was that, like I said before, how long can it cope? There's a dose-effect relationship. The longer the race goes, the average times here were 3, 5, 8 and 11 hours. And you see this dose response, greater RV function, the longer the hemodynamic stress is needed to go on. We just had a discussion about troponins and other biochemical markers, B-type natriuretic peptide, and I agree there's really not been any studies at all that have shown a relationship between biochemical markers of cardiac injury and left ventricular dysfunction. However, there's been 2 studies, one by Neelan and our study here, that shows a relationship between these markers and right ventricular dysfunction. Now, there's a number of confounders here because to properly measure troponin, you really, I think, need to have an area under the curve, if you like, and also there's a degree of scatter. However, I'm really confident that if we look harder at the right ventricle, we will find much stronger connect between right ventricular dysfunction and other surrogates of ventricular injury. The bigger question about what that represents in the long term, because let's remember when you do a race like this, your skeletal muscle's injured, lots of your body's injured and recovers. This is saying nothing about the recovery, but certainly the acute injury, both biochemically and functionally, is greater, affects the right ventricle to a greater degree. So if that's true, you would expect, if you're getting greater pressure on the right ventricle, greater injury after really prolonged training or racing, the right ventricle, even at rest, would become more chronically remodelled. And there's some good hints of this in the data. Here's some data from Arco Teske from Utrecht in the Netherlands. And he's shown this shift as we go from non-athletes to athletes to elite athletes, more and more training over more years, that you have a shift in right ventricular areas more toward abnormal values, bigger, lower functioning hearts. Also demonstrated basically exactly the same thing using the fancier tools of right ventricular strain and strain rate. Also showing it seemed to be more toward the base of the ventricle. Now, we heard earlier that with the athlete's heart, all 4 chambers should really increase in synchrony, symmetrically. And that's true. But there's shades of degrees of difference. And in this study, what we did was to compare because everything gets bigger, you need to compare one to the other. So the LV to the RV ratio. And here you can see that the ejection fraction is lower in athletes. The right ventricular to left ventricular ejection fraction is lower in athletes compared to non-athletes, and that the end systolic volumes are larger and the trend to the same for end diastolic volume, and the mass of the RV is bigger relative to the left ventricle. Now, I need to put this in the context of some other studies, particularly one by Gerche, who suggested that everything in this same ratio is symmetrical. However, our cohort were people who had exercised for nearly a decade more, and certainly that remodelling occurs over time. And we've seen this already, that some athletes, and in our series 13%, have these patches of delayed enhancement, which in our case were always in the septum or the hinge points between the ventricles. And I'll show you why I believe that is in a minute. But the interesting thing here was that we saw this delayed enhancement, which may be scarring, was associated with people who had done more sport, not put it here, but were the fitter athletes who had larger hearts, and particularly, again, of the right ventricle. Now, let me just give you some examples, because eyeballing is always easy. Those who do a lot of echoes will realise that this is a view that underestimates right ventricular size. And we always see that the annular distance here is less for the right ventricle than the left ventricle. The next three images I'm going to show you are all taken on the same day from the same professional cycling team, so not a selection of cases over many years. But what we see here is RV dilatation, right atrial dilatation, and you can see the septum here pushed from the right side over to the left. These are not normal findings, but we see commonly in athletes who have been competing at the highest level for many years. Here's another athlete, same cycling team. How often do you see a right ventricular free wall of 12 millimetres? You can see pronounced right ventricular hypertrophy. As I just explained, the ratio of right ventricular mass to left ventricular mass is greater in well-trained athletes. And finally, here is something that really looks quite odd, what we call rocking of the heart, with it moving from right to left, which we only see in cardiac dysynchrony, which this athlete did not have, or in relative right ventricular decreased function, if you like, with the whole heart being pulled across more by the left ventricle than the right. And so these are things that we're used to seeing in athletes. Now, we've developed in Leuven this technique because really the gold standard for the right ventricle is MRI. However, studying the right ventricle at rest, as I've told you, is absolutely useless. It's not doing anything. So we wanted to study the right ventricle during exercise. And so we did it in the MR machine. It sounds easy, but it's taken us a number of years to get right. But what I want you to do, I've compared here a non-athlete to an athlete with volume and pressure load to a patient with pulmonary hypertension in whom the pressure load is extreme. What I'll do, I'll just slow that down because it's too hard to look at this speed. So you can see the respiratory motion bringing things up and down. What I want you to focus on is, firstly, this is a normal heart. You have a left ventricle and a right ventricle that, even in this short axis view, looks a bit smaller. Here's your typical athlete, where you see this really considerable right ventricular remodeling. What I want you to focus on more so, though, so greater RV remodeling, but is this septal movement here. Here in the extreme case, you see the septum bouncing around between the two and pushing towards the right ventricle. In the non-athlete, you don't see that at all. In the athlete, you see something halfway in between. And so it really seems that both the chronic and the acute and everything about exercise is really on that path of really significant right ventricular work. And also, if you can put your mind back to those delayed enhancement pictures I showed before, you will remember that the delayed enhancement was here and here. And then look at where this sail, if you like, is whacking. This is the mechanical stress point. And so to me, it's not so much of a surprise that that is where we would see fibrosis or change in fibre rotation, whatever it is, but some sort of chronic structural change. And this septal movement representing, as I've been saying right throughout the talk, this greater RV pressure and motion. So if I was to summarise the entire talk, at rest, right ventricular pulmonary pressures are low, right ventricular function is normal, deformation is normal, the right ventricle doesn't have to do much. During acute exercise, the pressures can increase enormously, but the right ventricle copes. The areas at end systole decrease and deformation is maintained. But after 8 hours, whilst the pressures are normal, this is after exercise, the right ventricle is fatigued, it's dilated, the deformation is reduced, it's sustained this hemodynamic load for too long. The question, and this is the perfect segue between the two talks, is whether that, if it's repeated too frequently or with insufficient recovery, and in some athletes who may have other factors, whether it be training on top of illnesses or genetics, but in some athletes it seems that you can have this syndrome of overtraining of the heart, which may lead to clinical problems such as arrhythmias. And if that's the case, we need to be looking here at the right ventricle and not here so much the left ventricle. Thank you for your time.